Okay, you can start.
Very, very good morning, sir. Very good morning to all. Uh, my patient, 60 years old gentleman, is a resident of Udaipur. He is a retired government servant. He came with complaints of chief complaints of pain in the upper abdomen for past 6 weeks, also nausea and vomiting.
Hello,
आप मिल गया कितनी
Gopi, have you
Yes, sir.
कौन सा है पेशेंट दिखा रहे
ये देखना ये किसका नहीं लिखा है बता
ये ले 6 और 8 का बात है
Gopi, sorry, I could not hear you in the beginning, so maybe if you could
Sir,
start again.
I'm restarting.
Yes.
My patient, a 60
Yes.
years old gentleman who is a resident of Udaipur, is a retired government servant who comes with chief complaints of pain in the upper abdomen for past 6 weeks, also with nausea and vomiting. History of wrestling illness. Patient was apparently all right 6 weeks back. He developed pain in the upper abdomen for 6 weeks duration, which is incidence in onset, more in the upper abdomen, dull aching in nature, present throughout the day. It's not radiating to back. There is no postural variation. Aggravated by food intake. There is no relieving factors. Associated abdominal pain, associated with nausea and vomiting, approximately 1 to 2 episodes per day, which contain a gastric content around 100 to 150 ml. It associated with mild epigastric discomfort and no evidence of blood in the vomitus, which is aggravated by food intake in large quantity. And he had a history of melena is present, and history of yearly satiety, history of loss of weight, and history of loss of appetite is loss of weight and loss of appetite is present. He lost approximately 11 kg in past 6 weeks, and history of easy fatigability present. In the same time, also complaints of is having heartburn and regurgitation, and no history of dysphagia, no history of lump in the abdomen, no history of hematochezia, no history of bone pain, jaundice, cough with hemoptysis. Sir, may I proceed, sir?
Yes, yes.
Yes, sir. And past history, patient has no comorbidity, no history of prior surgery, and no history of similar complaints in the past. Personal history, patient consumes vegetarian diet. He had a normal bladder appetite, sleep pattern disturbed due to the pain, and no history of any drug allergy or no history of any substance abuse. Family history, his mother died of obstructive jaundice, chronic gallbladder cancer. They doesn't know in detail. And one of his mother's sister diagnosed having ovarian cancer, and his brother diagnosed having leukemia. He's on medical management, and presently they didn't got any record of his brother's treatment detail. Coming to summary, my patient, 60 years old gentleman, present with pain in the upper abdomen, also with nausea and vomiting, with significant loss of weight and appetite, also with melena for past 6 weeks, and with significant family history of malignancy in his family. And my provisional diagnosis, my first provisional diagnosis is gastric cancer.
Okay, let's start from the beginning.
Yes, sir. He present chief complaints of pain, abdomen, nausea, and vomiting for past 6 weeks, sir.
Yeah, so here you haven't mentioned the duration of nausea and vomiting. If the duration is same, then you could have said pain upper abdomen associated with nausea and vomiting for 6 weeks. But here vomiting is only for 2 weeks, so you should say pain upper abdomen 6 weeks, nausea and vomiting for 2 weeks. So
Yes,
we
sir.
know that this is the chronological sequence in which symptoms occurred. The presenting
Yes.
complaint should consist of or should include the main symptoms and their duration, both.
Yes, sir. Yes, sir.
Okay. Now, you said not radiating. You should specifically say where did you ask the radiation to?
So there is pain is not radiating to the back, sir.
Yeah, so because if a patient has upper mid abdominal pain, you should have specified, because upper abdomen could be mid, right or left. If the patient has pointed out, you should say. If he has not, then it is all right. So if it is upper abdomen, it could be gallbladder, it could be pancreas, it could be spleen, it could be anything. So radiation is characteristic of pancreatic pain, and radiation may be present in biliary pain. So if you are thinking of pancreatic pain, you should. मेरा echo हो रहा है, इसका on है क्या? So you should specifically say there is no history of radiation to the back. If you are thinking of biliary pain as a possible interpretation, you should say there is no history of radiation to the shoulder or to the back of the inferior part of the scapula. So at this level, even the negative history and negative examination should be specific, not like an MBBS student that there's no aggravating or relieving factor. So,
Okay, sir.
and similarly, when you say no relieving factors, what specifically did you ask? That does this relieve the pain? What did you ask?
Sir, is doing anything to relieve the pain, like is consuming a medication or is keeping.
So you should specifically say, if you are thinking of acid dyspeptic pain or pain of reflux esophagitis, you should ask whether you took any PPIs, whether you took any antacids.
Yeah.
You should ask whether the food, here of course there is a history of aggravation by food, but suppose that history is not there, whether food relieved the pain, whether any change in posture relieved the pain. So you should specifically mention that. Automatically tells me that you know and what you are thinking. Next.
Okay, sir.
Next slide. No, the previous one. Now, what is the most important thing to be mentioned in the vomitus in a patient where finally you are going to diagnose gastric cancer?
Sir, we have to whether it is a projectile vomiting or non-projectile vomiting, and associate any bilious content or non-bilious content. That is important.
Yeah, so
sir.
there are few things missing in your presentation. You did not describe the nature of vomiting. You did not say whether bile is present in the vomitus or not. You did not talk of presence of undigested food, which was taken maybe 12 hours or even 24 hours ago. So the characteristic vomiting of gastric outlet obstruction, irrespective of whether it is benign or malignant, is large volume projectile vomiting containing non-bilious material and may contain undigested food particles, food which was taken 12 hours, 24 hours, even 48 hours ago. Usually it occurs at the end of the day when the stomach gets full. So all these things have to be reflected in your presentation. The moment you mention all these words, I don't have to ask you anything else, and it is obvious that you are talking of gastric outlet obstruction. Okay?
Okay, sir. Okay.
Next. So early satiety. Early satiety is a part of the syndrome of gastric outlet obstruction. It starts with inability to take normal quantity of food, early satiety, postprandial fullness, nausea, and then frank vomiting. So it is a spectrum of symptoms. So this also should come along with when you describe nausea and vomiting. And I'm sure if you go into the details, patient will say that I started having early satiety few weeks ago, even before actual vomiting occurred. Okay.
Okay, sir.
How do you describe significant weight loss?
Sir, more than 10% weight loss over a period of 6 months, or more than 5% weight loss in a period of 30 days.
Check again. I think 1 month or 3 months? 1 month?
1 month, sir.
Okay. So whenever, if you are saying that approximately 11 kg, that means patient must have weighed himself before and after. You should say what was his original weight. You should always describe weight loss as so many kg out of so many kg. Of course, 11 kg in 6 weeks, irrespective of whatever was the original weight, is significant. So I'm not questioning that. But it is good to describe how much was the original weight and how much is the current weight if the patient knows it.
Okay, sir.
Why did you ask about heartburn and regurgitation? What is its importance?
Sir, actually, the patient himself describes is having a severe heartburn and regurgitation for past 6 weeks. So if I'm thinking in terms of associated G junction tumor or
So with this history, are you thinking of a G junction tumor?
No, sir. No, sir.
You are not. What
No,
is
sir.
the duration of these symptoms, heartburn and regurgitation?
Sir, he told for it is more in the past 2 weeks only, sir.
So if it is along with the current illness, it could be that when he was having gastric outlet obstruction, when he was not vomiting, maybe he was having some reflux, some regurgitation of the gastric contents into the esophagus, and that was causing heartburn and regurgitation. If it is long standing, then probably the unrelated reflux esophagitis, because it is important if you are thinking of G junction tumor, say a patient presenting with dysphagia, then this history is important. It
Yes,
could
sir.
be that there is long-standing gastroesophageal reflux disease, reflux esophagitis, leading on to Barrett's and then adenocarcinoma of the G junction. But in a patient with gastric outlet obstruction, it has no direct correlation.
Yes, sir. Yes, sir. But he predominantly is telling he's having a significant heartburn and regurgitation, sir. That's why I mentioned.
Yeah, that's okay. But then you should mention the duration.
Okay, sir. Okay.
And why is it that you have first mentioned history of melena and then much lower down you say no history of hematochezia? So GI bleed manifestations all should be mentioned. So you should have said no history of melena, history of melena, but no history of hematemesis and no history of hematochezia. The related symptoms should appear together, not disjointed.
Okay, sir.
And last line, why did you ask all these symptoms? Bone pain, jaundice?
Cough with hemoptysis. Sir, to know extent of the disease, because the patient is old age and with significant loss of weight and appetite, I'm thinking in terms of malignancy. So I asked, is having any bone pain or back pain to rule out spinal metastasis, and jaundice, it may be due to the liver pains or any lesion that compressed in the HDL, hepatoduodenal ligament, any most compressed hepatoduodenal ligament that causing a jaundice. Cough with hemoptysis, I have to rule out the pulmonary metastasis, sir.
Which is the commonest site of metastasis if you are thinking of a gastric cancer?
Sir, it will most commonly mess into the peritoneum only, sir, followed by liver, then followed by lung and bone metastasis, sir.
So why did you mention bone pain as the first? Bone is the last site of.
Yes, sir.
Again, when you mention more than two items or more than one item, they have to be mentioned in some order.
Okay,
and
sir.
the safest order to mention is statistical order. Common things first, less common later.
Okay, sir.
And it is a misconception amongst all students that liver metastasis cause jaundice. They do not cause jaundice. Liver metastasis will cause jaundice very rarely if there is a large metastasis located very close to the hilum or the biliary ductal confluence, when it is causing compression on a major biliary channel. Otherwise, liver metastasis do not cause jaundice. The other situation where there can be jaundice in liver metastasis is when liver is studded. Both lobes of liver are studded with multiple bilateral
liver
metastasis,
metastasis.
replacement of parenchyma. But these are rare situations. You don't mention jaundice as a metastatic history. It is wrong.
Okay, sir.
Similarly, pulmonary metastasis can cause dry cough by irritating the bronchus, but they don't usually cause hemoptysis. More common is pleural, malignant pleural effusion, which causes dull, diffuse pain in the lower chest. And the most important symptom or most common symptom is dyspnea, dyspnea on exertion. So it is not hemoptysis. It is dry cough. It is chest pain, dull, diffuse, continuous chest pain, and dyspnea on exertion. And lastly, bone pain, and if there is any history of pathological fracture on trivial trauma. So these are the common symptoms which you should mention in metastatic history. Liver metastasis, there are no specific symptoms. It is just anorexia and weight loss, which could be there even without metastasis.
Okay.
Next. What do you mean by similar complaints in the past? A patient with cancer will have similar complaints in the past?
No, sir. Actually, even if I'm thinking in terms of any benign gastric ulcer, in that.
But you did not mention that. If you're thinking of gastric ulcer, then you should have talked of history of symptoms of acid dyspepsia over a long period of time. So neither earlier nor here you have mentioned that.
Sir, there is no prior, any history of any acid peptide disease or
So it has to come out. It has to come out very clearly in your previous slide or here in the past history that there is no history of upper abdominal burning pain aggravated or relieved by food,
intake.
may or may not be associated with hematemesis, melena for a long period of time. So that is that you are describing whether patient had symptoms of acid dyspepsia or peptic ulcer disease. And then, yes, you are right, benign gastric outlet obstruction. So, but I'm asking that because in your differential diagnosis, you did not mention that. So gastric outlet obstruction because of peptic ulcer can be transient, can be reversible because initially it is caused by inflammatory edema and that settles either on its own or patient starts or patient reduces the oral intake or patient receives some conservative management and then patient starts eating again and then the obstruction may get relieved. So you should have then considered a possibility of a benign gastric outlet because the commonest cause of gastric outlet obstruction is still peptic ulcer disease. It's not CS stomach.
Yes, sir.
Okay. Next. So every sentence, every word you mention at this stage at the level of MCH has to be specific, has to be related, and has to be self-explanatory. Do you think his mother's history has any relationship with his current problems? Any theoretical possibility?
So mothers, at that time they haven't diagnosed it properly, sir. They doesn't have any records.
Suppose I say that it was confirmed CAGB. Could there be a possible relationship between his mother's illness and his problem?
Sir, actually, the upstage on this, I am not sure about the gallbladder cancer.
No, I tell you that it was gallbladder cancer. I have the records. I treated her. She had gallbladder cancer. Is there any relationship between gallbladder cancer and gastric outlet obstruction?
Yes, sir. Gallbladder cancer can cause gastric outlet obstruction if it invading the duodenum.
So a tumor in the fundus or body of the stomach can infiltrate the duodenum, even neck also, but and it can cause gastric outlet. So after biliary obstruction, gastroduodenal obstruction is the next common presentation, but gallbladder cancer presenting with gastric outlet obstruction alone is not a common presentation. So it is possible, although not probable, you will not make a diagnosis of GBC in a patient with gastric outlet obstruction. But you have to remember that after the two common causes, which are benign gastric outlet obstruction due to peptic ulcer disease and malignant gastric outlet obstruction due to CA stomach, the next two common causes are CA head pancreas and CA gallbladder.
Yes, sir.
Okay, next.
One of his mother sister
diagnosed
having ovarian cancer, sir.
So he has a strong family history of malignancy, mother and his aunt and his brother.
Yes, sir.
Although brother has a non-solid organ malignancy, but still. Next. No, next slide.
Yes, sir.
Yes. So again, because the duration of nausea and vomiting is different, you have to mention that he has pain abdomen 6 weeks, nausea and vomiting 2 weeks, and significant loss of appetite and weight.
Yes, sir.
And here, instead of directly making a diagnosis, you should say that you should not say diagnosis. You should say my interpretation or my analysis is that the patient has gastric outlet obstruction, most likely malignant gastric outlet obstruction.
Okay, sir.
Yeah. Okay. Carry on.
General examination. After obtaining a consent from the patient is conscious, well oriented to the time, place, and person, is moderately built and nourished, pallor is present, he is not icteric, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy, Patient having a raised beam in situ via the nostril. Patient BMI is 25.7 kilogram per meter square. Performance status is 1. His breath holding time is 30 seconds.
Hold on for a minute. So not related to case presentation, but why the P in person is capital? You have to be careful. See, everything you do reflects how much
Yes,
care
sir.
and attention you give to what you are doing. So once you make a presentation, always make it a habit to review it after 10-15 minutes and see where things are wrong. There are so many other mistakes which I did not point out, but all of you, it is, see, you must remember whatever comments I make, it is not directed to the student who is presenting. It is for everyone. So make sure that these things are not there. And why did you look for generalized lymphadenopathy?
Sir, in this scenario, the patient having a gastric obstruction, probably malignancy. So if I'm thinking in terms of lymphoma, so I just want to rule out the lymphoma. I'm checking out all the.
What is more common? If you have 60-year-old gentleman with gastric outlet obstruction of 2 weeks or 6 weeks duration with significant loss of appetite, what is more common?
Malignant gastric cancer, that is
Which
gastric,
malignancy?
adenocarcinoma.
So where does adenocarcinoma metastasize to in the neck?
Usually it is metastasis in the left supraclavicular node.
So you should have mentioned that first. You are right. So again, students, be careful. If your differential diagnosis is adenocarcinoma of an abdominal organ or in general surgery breast, then you are talking of supraclavicular node and in abdomen left supraclavicular node. If your differential diagnosis may include tuberculosis, then you are looking at all cervical nodes, especially upper deep cervical, jugulodigastric group of lymph nodes. If your differential diagnosis is going to include lymphoma, then you are looking at generalized lymphadenopathy, cervical, axillary, inguinal, even epitrochlear, which are characteristically involved in lymphoma. So if you have a young patient where the diagnosis is or clinical picture is highly suggestive of malignancy, or if the picture is suggestive of malignancy but duration is quite long, which is not usual with adenocarcinoma, then yes, you start thinking lymphoma. So I have no objection if you say generalized, but before that, you should have mentioned no left supraclavicular lymphadenopathy. And again, all of you mentioned cyanosis, clubbing, but in surgical patients, cyanosis and clubbing is less important. Icterus is important, pedal edema is more important. So again, if you have to mention, if you don't mention cyanosis or clubbing, at least I don't mind. But if you mention it before pedal edema, I have an objection. Pedal edema has to come first. That is more important.
Okay, sir.
So all the negative findings also have to be mentioned in order of importance, in order of statistics. Yes.
Vital signs. Patient is afebrile. Pulse rate is 86 per minute, normal in rate and rhythm. And respiratory rate is 18 per minute. And saturation at room air is 98%. Blood pressure is 120 by 70 millimeter of mercury in the sitting posture measured in the right upper arm.
So in a patient with gastric outlet obstruction who's been vomiting for 2 weeks, who has a rise tube in C2, what other important finding you should have looked for and mentioned in the general physical examination? What do you expect this patient to have?
Sir, general physical examination muscle tone is important, sir.
Why?
And because of recurrent vomiting, that can lead to hypokalemia, so the patient will be fatigued and having a less muscle tone. In the meantime, the patient, because of metabolic alkalosis, having hypocalcemia, they might having a carpophilar spasm while checking blood pressure, sir, because of hypocalcemia.
And
because of electrolyte imbalance, they may be disoriented and dehydration and disoriented.
Right, you're right. You're not wrong, but something which is much before all this, dehydration. You didn't mention his hydration status.
Skin turgor, yes, sir.
You should have mentioned the tongue. You should have mentioned his skin turgor. You should have mentioned other things. You're right that features of tetany, muscle tone, they are important, but dehydration is very important. So you have to look for features of dehydration. And you mentioned that he has a rise tube in C2. He doesn't have an IV line.
Sir, IV line is also there, sir.
If you have mentioned rise tube, you should have mentioned IV line also. That would explain that he's not dehydrated. Maybe he has been hydrated.
Okay, the patient also having a rise tube in situ, IV line and Foley's catheter is in situ, sir.
So if there's a Foley's catheter, you should have mentioned how much urine is in the bag, and you should have asked the patient or the relatives when was the last bag emptied. That will tell you whether he is producing good urine. So all these things are important. You see, in MBBS, when we examine a student, we are only assessing his knowledge, what he knows. At your level, when we are examining you, we want to know that tomorrow if this patient comes to you, how well will you manage this patient? So this is all you will have to look for. Suppose patient gets referred to you from a peripheral doctor, a general surgeon. Once the patient comes to you, you have to make sure patient is well hydrated. All this we will discuss when we discuss the management. So unless you look for them, how would you correct them? Okay.
Okay, sir.
And this patient may be a ward round patient. It may not be a long case. So there, all these things are very, very important.
Okay, sir. Yes, sir.
Carry on.
Examination of the abdomen. On inspection, abdomen is normal in contour. Umbilicus is centrally placed and midline. All quadrants are moved equally with respiration. No scar, no dilated veins, no visible peristalsis. Hernial orifice appears normal. There is no visible cough impulse. External genitalia is normal. And there is no visible lump over the abdomen. Spine is normal. Left supraclavicular and left axilla appears free, normal.
So this patient has a rise tube in C2, but suppose he came directly to you without any intervention anywhere. What finding would you expect to see on inspection?
On inspection of abdomen, I first skin turgor. I want to look about the dehydration. Second thing is patient having a history of gastric obstruction. So I just want to make sure the visible gastric peristalsis is present or not, and I can make
So
out.
you would expect, or it is possible that there will be fullness in the upper abdomen,
Fullness.
upper central abdomen, and at the left side, and there could be visible gastric peristalsis. So it would be better to say that the abdomen is flat, there is no fullness in the upper abdomen, and there is no visible peristalsis. But in the same breath, add that it is probably because the patient already has a rise tube in C2. So suppose I have missed your rise tube when you were presenting the general physical examination, I will not interrupt you. So when you describe no findings, you have to mention them and give a small explanation to that. At this level, at least I as an examiner am willing to accept that. So if I were you, I would say abdomen is flat. I don't see any fullness or visible peristalsis in the upper abdomen, but that may be because he already has a rise tube in C2 and the stomach has been decompressed.
Yes, sir.
Because maybe these findings were present before the rise tube was placed.
Yes, sir.
Okay.
Yes, sir. On palpation, abdomen is soft, not tender, no palpable lump, no organomegaly, no hepatosplenomegaly. On percussion, liver span is 13 centimeter midclavicular line, no free fluid. Tympanic is free, there is no free fluid. On parectal examination, tone is normal, no blood staining of melena or no deposit.
What were you expecting on the finger stall? You were expecting blood staining?
Not blood staining. There is a patient had a history of melena, so I am just looking for melena is present or not. Any black tarries.
So that should have come first. You should have said no melena, or the stool is not. Whether first you have to tell whether. So did you have stool on the finger stall? Was it
Yes, sir.
yellow stool or no stool?
Sir, yellow stool, sir.
So that you should have mentioned, because here I don't know whether there was a yellow stool or not. If it is yellow stool, then there is no question of saying that there is melena. If you don't have any stool on the finger stall, you can't say that there is no melena. Okay?
Yes, sir.
Yeah.
Respiratory system examination, bilateral, normal ventricular breath sound is present. There is no added or abnormal sounds in the bilateral lung field. Cardiovascular system, I can hear the first and second out sound. There is no murmur or added sound. central nervous system, there is no focal neurological deficit. Spine and cranium examination, there is no tenderness over the spine, there is no palpable lesion over the cranium.
So all these other systems mention only if you have examined. Have you really looked for any focal neurological deficit? If you haven't done that, don't mention it, or say,
Okay, sir.
I would like to examine the central nervous system, or I would like to get the central nervous system examined by a neurologist or a physician to look for any focal neurological deficit.
Okay, sir.
So most of the examiners would know whether you have done the examination or not. So don't say something which you haven't done. If you haven't done a rectal examination, say I didn't do a rectal examination because the patient refused or whatever reason. But if you don't do something, mention what, if you had done it, what were you looking for? So at least I know that you know what this examination is meant for.
Okay, sir.
May I interrupt, sir?
Yes, Rajin.
Yeah. Another thing is, in general physical examination, you should mention about skin changes. What are the skin diseases associated with carcinoma stomach?
There is hyperpigmentation,
No.
hyperkeratosis and parakeratosis might be present, sir. And
Okay. What is that called? Is it pigmented or not pigmented?
is it pigmented, sir?
What is that called?
Sorry, I forgot the name, sir.
Yeah, Sudeep Kanungo has answered. Acanthosis nigricans, which is usually seen in the axilla and groin in diabetic patients. But all other areas, if it is involved, then you should think of acanthosis nigricans of malignancy. If it is just in the axilla or in the groin, then you should check whether the patient is diabetic. And if he is diabetic, you can say it's due to diabetes and not due to cancer. Also, the duration is, it may proceed by many, many months. And when you're suspecting gastric outlet obstruction, you can't rule out other tumors in the area which cause gastric outlet obstruction, like carcinoma gallbladder, carcinoma pancreas, carcinoma duodenum. All these can cause gastric outlet obstruction, not gastric carcinoma. So you have to give us a differential diagnosis.
So you see, it would be better to say gastric outlet obstruction, possibly malignant. Because as Dr. Desai pointed out, even CA duodenum, although it is less common than CA stomach, depending on its location, if it is in the first or second part of duodenum proximal to the papilla, it will cause bilious, non-bilious vomiting, exactly like gastric outlet obstruction of CA stomach. On the other hand, if it is D2 beyond the papilla or D3, again, it is called gastric outlet obstruction, but it is associated with bilious vomiting. So, tumor of the uncinate process may not cause jaundice, but can cause gastric outlet obstruction, but that vomiting will be bilious. On the other hand, CA head pancreas causing gastric outlet obstruction, but no jaundice is unusual, uncommon. So, if you see gastric outlet obstruction, but there is no jaundice, and say ultrasound or CT shows a mass in relation to head of pancreas, then most probably it is uncinate process.
Okay, sir.
Yes, carry on.
Summary: 60 years old gentleman, present with pain in the upper abdomen for past 6 weeks, also with nausea and vomiting for past 2 weeks, with significant loss of weight and appetite, also with melena, and he had a significant family history of malignancy in his family with unremarkable abdominal finding. And
it is the correct term is no remarkable abdominal finding or unremarkable abdomen. But here you should add with a Rice tube in C2. Because maybe Rice tube has taken care of some findings like visible gastric peristalsis or a dilated stomach, which could have been seen, which could have been percussed. And on the other hand, if you decompress the stomach, one finding may become more prominent. What is that finding? Which you may not have been able to look for when the stomach was distended. If there is a lump in the pre-pyloric or pyloric area. Okay. So when you have a distended stomach, you may not be able to feel it, but once you decompress, so you should always examine the patient after adequate decompression of the stomach. And if you do that, sometimes you may be able to feel a lump which was not there earlier.
Okay. And
Yeah.
Sir, can I interrupt again?
Yes, please.
What is your interpretation if a rice tube has been poured? What are the reasons why you prepare the stomach that way? One is to relieve vomiting, but what are the other causes and reasons?
Sir, first putting a rice soup to decompress the stomach, sir, because having a
Why? Why?
Why do you want
Suppose
to decompress the stomach?
you can suction it out on the operation table, but you don't do that. You give a 2 weeks decompression with the nasogastric tube. Why?
And if we want to prepare the patient for further investigation like upper GI endoscopy, we can give a lavage, sir, to the.
So why do you want to
stomach.
do that? As Dr. Desai said, endoscope has a suction channel. When you put the endoscope, you can suck it out.
Sir, we need a proper lavage prior to upper GI endoscopy to visualize the entire stomach and entire gastric mucosa, sir. To rule out,
You are right, but is that the primary reason?
What is the
Primary-
surgical reason?
Surgical reason, sir, and we can rule out the aspiration of the content whether there is any active bleeding is present or not. We can make out by keeping a rice tube. And in the
Okay,
meantime,
I'll put the question in a different way. What happens to the normal stomach in gastric outlet obstruction?
because of the extensive distension, it will lose its tonicity, sir. To
Loss of?
tonicity of
Yeah. And what about the gastric wall?
gastric wall will be edematous.
Precisely. So all this you want to reduce before you attempt any surgery on the stomach. Because
Yes,
if it's edematous and you put your sutures, the signs of leakage, the chances of repeat gastric outlet obstruction at a different time once the edema subsides are higher.
So there are multiple reasons why you place a rice tube in a patient with gastric outlet obstruction. Primary, of course, is that it takes care of the vomiting. Second is inevitably or almost all cases, these patients will require an upper GI endoscopy. If you put the scope in a patient who has a distended stomach with lot of solid food material, the moment the scope goes through the GE junction, there will be reflux of the material and the patient can aspirate. So you don't, and same holds true in a patient with achalasia. You should not straight away take the patient with achalasia to endoscopy because this patient can aspirate and die on the endoscopy table. So the esophagus also needs the same preparation by placing a nasoesophageal tube and decompressing the esophagus. Then, as Dr. Desai said, this distended, chronically obstructed distended stomach is atonic. It is edematous. So you want to take care of that edema so that your sutures hold. And atonic, because then even if you do a drainage or you do a resection and do a gastrojejunal or gastroduodenal anastomosis, the stomach will take time to recover its function, whereas decompression helps it, like a distended urinary bladder when you place the Foley's catheter. So all these are the reasons why you place the rice tube, but the most important reason is to prevent aspiration during endoscopy. And you rightly said that a full stomach is difficult to evaluate, whereas an empty stomach, clean stomach is easier to evaluate. But that is the secondary reason. And somebody asked the duration. I think it is usually about 24, 48, maximum 72 hours. The best is that when the returns become clear. So you put saline and saline comes out, you know that the stomach has been cleared. Yes. Carry on.
Okay, sir. At this stage, my provisional diagnosis is gastric outlet obstruction due to malignant gastric lesion.
Why is this not benign?
First, the patient is old, it's more than 60 years with 1.5 month history of all the symptoms with significant loss of weight and appetite. And he is having a strong family history of cancer. So all these history and finding of suggestive of most probably a malignant gastric lesion, sir.
And no past history to suggest acid dyspeptic
acid-
disorder. Although it is not that all patients who present with benign gastric outlet obstruction will have a history of acid dyspepsia, but less likely. So if there is no previous history to suggest peptic ulcer disease, elderly patient, short duration, significant weight loss, a reasonably strong family history of malignancy, all these things, yes, you should mention, you can mention as the diagnosis is malignant gastric outlet obstruction, and then comes the organ or the site of malignancy. So again, statistically speaking, CA stomach, which is usually in the prepyloric region, then CA duodenum, first and proximal second part, unlikely to be CA head pancreas because there is no jaundice, unlikely to be CA uncinate process because which can be without jaundice because the vomitus you did not mention, but I presume it is non-bilious, and a rare cause could be fundus or body gallbladder malignancy, which is infiltrating the duodenum.
Okay, sir.
Next.
Sir, I would like to admit the patient. I would like to do the investigation to confirm diagnostics.
So the first aim suppose he comes to you de novo with this history, your first aim is to confirm the diagnosis?
No, sir, I will admit the patient. I will resuscitate. I will stabilize the patient. Then my first
stabilize resuscitation from what? His hemodynamics, you said vitals were normal. What stabilization?
Sir, actually, that patient already admitted and stabilized, sir. So if the patient comes with this history, if the patient's dehydration or electrolyte imbalance,
you
I will
have
correct
to understand. You have to understand the difference in meaning of the words resuscitation, stabilization, and optimization. These patients are likely to have dehydration and metabolic derangement. Unless the dehydration is severe enough to cause hypotension, then yes, resuscitation and stabilization is. Resuscitation is of a patient who is hemodynamically unstable. Here he is likely to be fluid and electrolyte wise unstable. So that is what is called resuscitation or optimization. So the first aim of management of a patient with gastric outlet obstruction is correction of fluid and electrolyte and metabolic imbalance. So your first investigations will not be for diagnosis. The first investigation is to find out what is his electrolyte profile and what is his ABG profile. That will be the first investigation to do.
Yes, sir.
So do we have that before the resuscitation or correction was done?
Sir, on 22nd, they did a basic blood profile. Blood profile.
So what would you expect? Suppose he came to you without any treatment. What did you expect to see in the investigations?
Hypokalemia, hypochloremia, and ABG features of metabolic alkalosis findings, sir, because of gastric outlet obstruction.
Anything in the hemogram?
Hemogram, it because of dehydration might be concentrated, and you need to check with them.
Yeah, so you should always start from hemogram, then you should go to renal functions. You expect his urea to be high, creatinine may be high, and then there will be electrolyte imbalance. So whenever again you mention things, you should mention in sequence, and sequence is hemogram, renal function. Here LFT is not important, so hemogram, renal functions, and electrolytes, and then ABG. Okay. So we will
skip that. What if you have megaloblastic anemia? What would be the impression that you would develop if this patient had megaloblastic anemia? In addition to all these features,
I will think in pernicious anemia. Pernicious anemia.
So have you ruled out pernicious anemia as an associated cause for CA stomach? Nowhere in the history you mentioned any of the features of B complex vitamin deficiency.
The patient censoring is normal, sir. So,
what are the lesions you can get in pernicious anemia other than carcinoma of the stomach? Achlorhydria will be there.
Achlorhydria will be there.
Yeah, and, because of that, what do you develop?
Megaloblastic anemia will be there, and features it can be related to vitamin B12 deficiency.
Yeah,
neurological dysfunction and weakness will be
glossy tongue, chelosis. all these will
Pediatric
support a
pathology.
diagnosis of megaloblastic anemia. These are other B vitamins which cause this, like B1 and B6. But they go hand in hand with B12 deficiency in pernicious anemia.
Okay,
So
sir.
since Dr. Desai was asking you about systemic manifestations of malignancy and especially CS stomach, another common thing which it would be good, it will earn you some brownie points if you mention that there's no evidence of deep vein thrombosis. In fact, CS stomach, CA pancreas, they are
Yes, sir.
associated with deep vein thrombosis. And as he mentioned, the deep vein thrombosis may come first and CS stomach may be detected later or CA pancreas may be detected later. Okay, I think we will skip this because this is more theoretical, but all of you should know because this is again a favorite question in the theory exam, the metabolic and electrolyte imbalances in gastric outlet obstruction and how to correct them. So all of you must know that.
Okay, sir.
Yes.
In blood parameters, the platelet is 1.5 lakh, which is just above the normal, and potassium is on hyperkalemia side, sir. 5.5 milli per liter, and blood urea and creatinine is normal, sir. And
Okay, so how will you now, the patient has already been optimized, all the disturbances have been corrected. How will you confirm the diagnosis?
sir, to confirm my diagnosis, I want to do the upper GI endoscopy, sir.
Let's see. So we have already discussed that upper GI cannot be done straight away. It has to be after proper preparation of the patient and of the stomach, both.
Yes, sir. Yes, sir. And upper GI endoscopy, sir. Esophagus, there is a mucosal bed more than 5 millimeter involving more than 75% circumference, suggestive of esophagitis grade D on Los Angeles classification. And the anthem is edematous, infiltrate and thickened mucosa with deformed pylorus. They took a biopsy. They enter the duodenum. Duodenum is edematous, infiltrate, thickened mucosa. D1, D2 junction is narrowing. Scope cannot be negotiated. Impression is gastric outlet obstruction, cori nature, cori malignant, and they took a biopsy. In the meantime, the patient was having esophagitis.
So if you were the endoscopist and you saw these findings, what will be your assessment?
Sir, in the
You don't know the
meantime,
history. You don't know the history. You are just doing endoscopy. If these
Yes,
are
sir.
the findings, what will be your assessment?
uh, I will check one more thing, sir, whether the stomach distendability with insufflation, if it is present or not. I will check. In
How
the
does
meantime,
that help you? If it is distensible, if it is not distensible.
so here the mucosa is edematous. But if the stomach is not distensible, I will think in terms of linitis plastica.
But the fundus and body, they said, is normal. It is,
Yes,
in
sir.
fact, they are saying full of food, so which means that probably it is distended. The lesion is, or the pathology is confined to antrum and D1, D2. Or D1 only, up to D1, D2 junction. So you are
What
right.
is the significance of, excuse me, can I interrupt, sir?
Yes, yes.
Yeah. What is the significance of duodenal involvement in tumors of the distal stomach? In which condition it will be involved and in which condition it's unlikely to be involved?
Sir, patient who already had a H. pylori associated gastritis, there may be a metaplasia develop both in the stomach and in the duodenum, sir.
Is that the reason or is it something else?
Something else, sir.
So between the
I'm
two
not sure.
malignancies, Dr. Desai asked you that in which malignancy duodenum is likely to be involved, in which it is less likely to be involved. There are two
Basically
malignancies.
pushing you towards lymphoma or
Lymphoma.
carcinoma.
See, adenocarcinoma generally does not extend into the duodenum.
Duodenum.
It
Yes, sir.
stops at the pylorus.
Yes, sir.
Whereas if there is a contiguous involvement of both the antrum and duodenum, it is more likely to be lymphoma. And you were right when you said that distensibility. So distensibility will not be there if it is linitis. But here fundus and body are normal. So even if it is linitis, it is probably localized linitis. And the second possibility where the wall is thickened, non-distensible, is a lymphoma.
Yes, sir.
And the other point here in favor of lymphoma is that both stomach and duodenum are involved.
Yes, sir. Yes, sir.
Okay? But as I said, if you don't know the age or if you don't know the history of patient, you only look at endoscopy findings. These findings can be there in benign gastric outlet obstruction also, thickened
Yes,
edematous,
Yes, sir. Benign gastric.
because there are no nodules, there is no growth described. So it is very difficult to say what it is. Okay.
Okay, sir. Sir, they took a biopsy, sir. The
Yes.
biopsy took on outside. We have a biopsy report, sir.
What does it show?
Biopsy, which is suggestive of suspected low-grade lymphoproliferative disorder.
Suppose the biopsy was negative, inconclusive, no malignancy, no granuloma.
Yes, sir. In that scenario, I would like to do the endoscopic ultrasound.
No. What will be your interpretation before you do something? What will you think? You saw this endoscopy picture, biopsy is negative. What comes to your mind? So since we are already at 10, if you have a young patient, as I said, strong history of malignancy, any imaging shows diffuse thickening of the viscous, whether it is stomach, small bowel, large bowel. And if you see something, especially edema and thickening, and biopsies are negative, immediately lymphoma should come to your mind. The second possibility which should come to your mind is tuberculosis. Okay. So,
Okay,
and in that situation, you attempt to do a deeper biopsy. How do you do a deeper biopsy?
Sir, either we can do with endoscopy or we use under the guidance of UF. We can go ahead with a well biopsy, sir. You have to take minimum.
So well biopsy is endoscopy. Well biopsy means that you take a biopsy at one place. At the same place, you take another biopsy, then you take another biopsy. So you are trying to go from the mucosa into the submucosa, because both of these lymphoma and tuberculosis will be submucosal lesions. So that is what is called a well biopsy or a biopsy on biopsy. The other is, I think, check with your endoscopy colleagues. There are larger biopsy forceps now available. So they give you a bigger chunk, and that is how you get deeper. And third is the fine needle aspiration cytology, because when you do an EUS guided FNAC or a needle biopsy, a core biopsy, you puncture the mucosa and you get into the wall of the stomach. So these are the ways that you can get a tissue diagnosis in a patient where first biopsy is negative. So the moment you get a negative biopsy and you see diffuse thickening of the wall of the viscous, lymphoma should come to your mind.
Okay.
I think we need. Yeah, Rajen.
The same patient also underwent endoscopy in our hospital, sir. This is a endoscopic picture and endoscopic finding. Endoscopic finding, thickened ample fold, very suggestive of lymphoma, sir.
Yeah.
Actually, they also took the biopsy in our hospital.
Yes.
And the biopsy is suggestive of mildly inflamed gastric mucosa. No evidence of any granulomatous.
So two biopsies being negative, definite gastric outlet obstruction, you are seeing edematous thick mucosa is very strongly suggestive of a lymphoma. I think we will close here. So
sir,
students,
the patient underwent a PET CT outside, sir. We'll see the film only, sir.
What did it show? Just tell us the report.
Just a minute. PET CT head and neck region, the right lobe of thyroid, there is hypotenuse lesion of 1.5 cross 1.2 centimeters, suggested UC correlation. In the chest, multiple FDG with bilateral upper and lower paratracheal subcarinal bilateral node, suggested in the stomach, low grade FDG with heterogeneous enhancing symmetric thickening, maximum SU of 3.2, the length involving about 9 to 10 centimeters, maximum wall thickness about 2.5 centimeters.
Yeah,
Noted in
again,
the distance
again,
about-
this suggests a possibility of a lymphoma. Milton asked that is it necessary to mention negative B symptoms? You see, if based on your history and examination, you thought of lymphoma, then yes. Otherwise, if you mention, then I will know that you know the final diagnosis. So in a 60-year-old gentleman who's presenting with features of gastric outlet obstruction, significant weight loss, clinical diagnosis will still be CS stomach. I don't think that would change. So I'm not sure whether I would mention the negative. Now you can go back and ask. That is different.
Okay, sir.
So I think we will close. Students, please send me a mail, bkkapoor.india@gmail.com. Write stomach in the topic of the mail. I will send you the chapter on stomach. So we'll close. Thank you, Rajen. Thank you.
Thank you.
Thank you, sir.
Sir.
Thank you, Gopi. Thank you for presenting.
sir.
Thank you.